Here are 10 things about cavernomas in 90 seconds. Cavernomas are low-flow, low-pressure lesions that are not visible on an angiogram. 80% are located above the tentorium, 15% in the brainstem, and 5% in the spinal cord. For incidental lesions, the rate of symptomatic hemorrhage is 0.5 to 2% per year for superficial lesions, 2 to 5% per year for spinal cord lesions, and 5 to 10% per year for brainstem lesions. The Zabramski classification divides cavernomas into type 1A, type 1B, type 2, type 3, and type 4. Cavernomas can be sporadic or familial. Natural history of both is similar, but overall risk of bleed is higher in familial cases due to higher number of cavernomas. Radiation can also induce cavernomas, which have a high risk of bleed. Some cavernomas are associated with a developmental venous anomaly, which always needs to be preserved. For asymptomatic cases, surgery can be considered for lobar and cerebellar lesions in non-eloquent cortex, exophytic periventricular lesions, and brainstem lesions abutting pial surface. For symptomatic cases, surgery is considered for refractory epilepsy, non-eloquent lesions with bleed, and eloquent lesions with multiple bleeds. Hemosiderin-laden brain surrounding a cavernous malformation should not be removed unless the lesion is in non-eloquent cortex and the indication for surgery is epilepsy.